Okay, thank you very much for having us and inviting us to this ed. Knowledgeable talks. Today, I'm delighted to co-chair with Professor Shiv Kumar from UCLA Cardiac Arrhythmia Center this session on cardioneuroablation, which is indeed a very hot topic. We will have 3 talks from Dr. Pashon, who is the father of cardioneuroablation, and he will talk about the basic concepts. Then we'll have Dr. Yang Yao, who is having a late night today. It's almost 2 o'clock in the morning there in China, and he will talk about cardioneuroablation for vasodepressive syncope, their initial results. Then we're going to go and have a great talk from Dr. Aksu from Turkey, who will talk about cardioneuroablation for treating functional AV block. And we will close with the group from Dr. Pashon that will, Dr. Serpa, who will be talking about cardioneuroablation for paroxysmal atrial fibrillation. At the end, we will have a panel of discussion. You can send your questions through the chat, and both Dr. Shiv Kumar and myself will going to co-chair and make this session very interactive. Again, thank you very much for the invitation, and we're going to get started now.
Greetings to everyone. It is a great pleasure and a privilege to be participating in Latin American Heart Rhythm Society Virtual 3rd Scientific Session. Thank you very much, Dr. Luis Sainz and Dr. Marcio Figueiredo, by the invitation, and congratulations by organizing this remarkable meeting. Greetings to our dear friends, Professor Shiv Kumar and Professor Morillo, for heading this event. Our mission is to address the theme Cardioneuroablation Basic Concepts, Current Technique and Potential Indications. I'm Professor Pashon, Director of the Arrhythmia Service of São Paulo Heart Hospital and Professor of Post-Graduation Program at the University of São Paulo. There is nothing to be disclosed. The cardioneuroablation is a method to get vagal denervation based on endocardial radiofrequency ablation. In the 90s, by studying the atrial myocardium by using the spectrum analysis, we observed that the atrial myocardium is composed of a very well-connected myocardium, the compact myocardium that presents a smooth spectrum and isotropic conduction, and by another one, the fibrillar myocardium composed of loose cells, disconnected cells, that present a very segmented spectrum and anisotropic conduction. Clusters of fibrillar myocardium are named the atrial fibrillation nest. The disconnection of the cells may be caused by the entrance of the innervation that disconnected the cells, or also by the transition to the atrium to the pulmonary veins. In this region, there is a scattering of the cells causing the atrial fibrillation nest. So, in the connection of the pulmonary veins, there are high number of atrial fibrillation nests, and also in the innervation entry. So, the mapping of the atrial fibrillation nest may be used to get a tracking of the innervation of the heart. Ablation of the atrial fibrillation nest along the atrial wall in the right and left atrium caused a remarkable vagal denervation. In this example, the patient presenting an SDNN of 130 milliseconds went down to 27 milliseconds after the atrial fibrillation nest ablation. So we realized that the ablation of the atrial fibrillation nest could be a way to get vagal denervation by radiofrequency ablation. Based in this possibility, we proposed the cardioneuroablation as a new treatment for neurocardiogenic syncope, functional AV block, and sinus dysfunction using catheter RF ablation. The aim was to get significant long-lasting vagal effect attenuation. Here we have a summary of the myocardium classified by the spectral analysis. The compact myocardium composed of very well connected cells, and the atrial fibrillation nest. The atrial fibrillation nest physiological is type 1, and type 1A caused by the innervation entry, here in a study by Dr. Shiv Kumar. And here the atrial fibrillation nest, namely the 1B, that is caused by the transition by the scattering of cells from the atrial wall to the pulmonary veins, and at the end, the pathological atrial fibrillation nest, the atrial fibrillation nest type 2, that are formed and caused by the disconnection of the cells by fibrosis. Here, the innervation may be observed in the endocardium, stained in a white color. The left atrial endocardium presents more innervation than the right atrial endocardium. The histology of the innervation, in this case stained in a dark color, shows that there is more innervation in the endocardium than in the epicardium. So the cardioneuroablation is better to be performed by the endocardium. Here it is possible to observe that there are high amount of neural fibers running along the myocardial fibers, between the myocardial fibers, causing some kind of disconnection, some kind of electrical disconnection of these cells, and this disconnection changes the spectrum and features the atrial fibrillation nests. Let's see now something about the curing technique of the cardioneuroablation. Scheme of the cardiac autonomic nervous system. There are three main branches, the parasympathetic, the sympathetic, and sensory, and only the parasympathetic is prone to be eliminated by cardioneuroablation because only the parasympathetic one presents the postganglionic neuron in the atrial wall. The neurons of the sympathetic and sensory system are located far from the heart, so they recovered after the ablation. It is important to remember the position of the ganglionated plexi that present a high number of postganglionic neurons, mainly the parasympathetic postganglionic neurons. They are located between the superior vena cava and aorta, the first ganglionated plexi, the second one at the insertion of the right pulmonary veins, the third one at the insertion of the inferior vena cava and coronary sinus ostium, and the fourth one at the insertion of the left pulmonary veins. In order to get important vagal denervation, it's necessary to apply more radiofrequency in areas, in the regions overlapping the ganglionated plexi. The radiofrequency energy may overpasses the atrial wall, causing even lesion in the esophageal wall. So it is easy to understand that the radiofrequency applied in the right place may cause ablation of the ganglionated plexi. How to check the vagal denervation? It is very important to have a way to see the denervation degree during the cardioneuroablation. In 2015, we published a way for extracardiac vagal stimulation that allow us to see the denervation degree, the denervation progression during the procedure. It is easy to be performed by advancing a catheter inside of the internal jugular vein up to the jugular foramen. In this region, the vein and the vagus are very, very close, and the vagus may be stimulated without contact by using a customized neurostimulator with very strict features of safety that makes possible to deliver pulses with 15 hertz, with 15 microseconds, and with 1 volt per kilogram up to 70 volts. By turning on the stimulation, it's possible to observe the immediate asystole caused by the acetylcholine, caused by the vagus stimulation that disappears some seconds after. And this kind of effect disappears completely by atropine infusion, by intravenous atropine. This kind of stimulation may be obtained by using the Grazi stimulator or even by using the electromyography. However, it's very important to pay attention to the amount of energy because safety reasons. How to check the vagal denervation? Here we can see a short movie showing the progression of the catheter up to the jugular foramen and the stimulation of the vagus in this area. Here there is an example of a patient with a severe cardioinhibitory syncope pre-cardioneuroablation. The vagal stimulation causes a very long pause even with several blocked P waves because the inhibition of the sinus node and the AV node. After the cardioneuroablation, the vagal stimulation was repeated and there is no more asystole, no more blocked P waves, no more pauses, showing that the denervation was successful. Here we can see the map of the cardioneuroablation. This procedure is performed by ablating mainly in the left interatrial septum, in the insertion of the coronary sinus, in the roof of the coronary sinus by the left atrium, in the insertion of the superior vena cava, in the insertion of the inferior vena cava. Depending of the case, many times there is no enough denervation by ablating these areas, so it is necessary to ablate more, for example, in the insertion of the pulmonary veins and also in the Waterstone groove. It is important to resume the ablations until to have the complete denervation by using the extracardiac vagal stimulation. The main target in cardioneuroablation is the area so-called P point. This area is located in the left atrium, in the interatrial septum, between the insertion of the right pulmonary veins and the roof of the left atrium and the fossa ovalis. This area must be extensively ablated. And here we can see the results of the P-point ablation. There was a reduction of 7-fold in the duration of the pauses caused by extracardiac vagal stimulation. It is the main target for obtaining the sinus node denervation. Cardioneuroablation results and potential indications. Here, an example of cardioneuroablation in the treatment of malignant cardioinhibitory vasovagal syncope case of a 16-year-old boy presenting generalized tonic-clonic seizures and syncope since 5 years old. He was treated with anti-epileptic drugs, and here we can see the results of the TUT test that caused a very long asystole of 28 seconds. And at this point, the TUT test reproduced the grand mal seizure. This patient was referred for cardioneuroablation. We can see the cardioneuroablation that was performed in that patient. In this case, it was at the beginning of the procedure, it was performed an extracardiac vagal stimulation, showing a very long pause, a very long asystole that was ended by a very, very slow sinus rhythm we can see here. It was caused only by 5 seconds of vagal stimulation. And here, after the cardioneuroablation, it is possible to see again the 5 seconds stimulation of the vagus. There is no more asystole, there is no AV block, no more pauses, showing that the denervation is successful. 8 months after the cardioneuroablation, the tilt test was repeated and was completely normal. The patient is going very well without syncope and without medication. So it is an example of the cardioneuroablation for treating a severe case of cardioinhibitory vasovagal syncope. Does the cardioneuroablation causes long-term denervation? Yes, it does. This is the result of a study of 83 patients submitted to cardioneuroablation and studied over 2 years of follow-up. It is observed that the SDNN was reduced by 34% and the LF was reduced by 78%. So the denervation was of the parasympathetic system, but also the denervation was of the sympathetic system. So the conclusion is that the cardioneuroablation causes a long-term denervation, a long-term reduction, a long-term attenuation of the vagal innervation and also of the sympathetic innervation. It is very important to know if cardioneuroablation causes arrhythmias. In this study of 83 patients followed by more than 2 years, we observed that the cardioneuroablation caused an important reduction of the ventricular arrhythmias, caused an important reduction of supraventricular tachyarrhythmia, and a very important reduction of the functional bradyarrhythmia in this group of patients. So our conclusion is that cardioneuroablation does not cause arrhythmia. It is not an arrhythmogenic procedure. The long-term results of the cardioneuroablation. Here we can see the comparison of the Kaplan-Meier curves of the cardioneuroablation compared to the clinical treatment and the pacemaker. It is clear that the cardioneuroablation, the clinical treatment and pacemaker, and there is a very important observation that the cardioneuroablation based on the complete elimination of the vagal effect, the best result compared to the classical cardioneuroablation without control of the vagal denervation. So in our service we used only the cardioneuroablation controlled by extracardiac vagal stimulation, and the endpoint, the best endpoint, is to eliminate completely the vagal effect. At the end, let's see the cardioneuroablation potential indications. All the patients must have the inclusion criteria that are symptoms clinically refractory, absence of significant cardiopathy, and normal response to atropine. It is absolutely important. Based on these inclusion criteria, all the patients presenting reflexes and non-reflex bradyarrhythmias may be treated like cardioinhibitory vasovagal syncope, mixed vasovagal syncope, situational syncope, neurogenic ictal bradycardia, glossopharyngeal neuralgia, and vasodepressor vasovagal syncope, sinus nodes dysfunction, functional IV block, bradytach syndrome, vagal atrial fibrillation or paroxysmal atrial fibrillation, carotid sinus syndrome, familiar bradyarrhythmia, and overtraining bradycardia. Cardioneuroablation is a safe method for vagal tone attenuation that makes possible to treat vasovagal syncope and functional bradyarrhythmias without pacemaker. The results are being reproduced by many worldwide studies. It has a decisive and inexpensive pre-procedure tool for predicting the results and for long-term evaluation, that is the atropine test. it has the extracardiac vagal stimulation that is a highly effective tool for getting the hard endpoint during the procedure, that is the complete vagal effect elimination. And finally, the heart rate variability shows that the cardioneuroablation causes a persistent long-term vagal denervation. Thank you very much.
Hi, greetings from China. Thank Dr. Pachon for inviting me giving this presentation on cardioneural ablation in visual depressive vagal syncope, our initial results. Sorry that I'm traveling in South China right now, so I can only perform this in my hotel rooms. We start to perform HF ablation by using the long contact array mapping technique since year 2003. And we observe a very interesting phenomenon that more than 80% of a chance we may see the vagal reflex joint ablation at the roof near the LSPV orifice. So in year 2007, March, a lady at her mid-40s came to us, who claim has a over 30 years history of frequent syncope whenever she bend her body or change her position rapidly. And we found she had a mixed type positive held up test results. And by performing this omega linear lesion set, we observed this vagal reflex again in this roof close to the LSPV. And after ablation, both HF ablation and syncope gone, and which lasts to more than 10 years by now. And after 2 cases within half months, we gain confidence to try to use this technology to treat the vagal syncope. So, previous study by Oklahoma, Sandy Push group, they found there are ganglion plexus located in different positions of the left atriums, which you can see very much like our omega lesion sets. So, the vagal syncope is one of the most frequent syncope type in clinic and has been recognized for over 300 years. And currently, the diagnosis of vagal syncope is only based on the clinical manifestation and history, according to the ESC and the HRS. So, people may use Calgary score as a diagnostic tool, but however, the specificity is very low. So, although the held-up test is not recommended as a diagnostic tools, but we still perform this test in every patient who suspect as a vagal syncope, just to try to classify their types. And by performing this tilt table test, you may classify the patient into 3 types, and including mixed, cardioinhibitory, and visual depressive. In recent years, people noticed you can also evaluate the activity of the autonomous nerve system by using the deceleration capacity, which provided by the heart monitoring plus special algorithms. The lower DC value is, the higher sympathetic nerve activity. So the current therapy for vagal syncope, I should say, is somehow frustrated. Except education to the patients, seems like there is not any effective therapy to the patients. However, previous study, experimental study, indicate ganglion plexus ablation may affect sinus rhythm, AV load, interval, and ERP. To ablate the ganglion plexus, you need to target the location of this GPs. So Oklahoma group developed a high-frequency stimulation protocol, which use 20 to 50 hertz, 10 to 150 volts. We normally perform with 20 and with up to 10 milliseconds post-VADIS. And normally delivers only 2 to 5 seconds to avoid eliciting a sympathetic response. This is a one more example, a mixed type syncope patient, a female. This is the baseline data. So we performed this ablation 3.5 years ago by using NAPC systems, and we use MicroPace 3 as our stimulators for ganglion plexus targeting. So you can see high frequency stimulation at the roof on the left side of the left atriums induces lung pulse nearly 4 seconds. That's the location of LSCP. So high frequency stimulation on the right side also induces this lung pulse. So the positive high frequency stimulation defined as the sinus rhythm decrease more than 50% or lung pulse more than 2 seconds with sinus pulse or AV block. You can also see this positive vagal reflex during the ablation, the same deflation. So these are the locations or the distributions of the ganglion plexus. If one is familiar with this location, you can also try to target or ablate ganglion plexus if you do not have a stimulator to perform the high frequency stimulation. In this case, ablation at the left atrium shortened the PR interval from 220 to 133. And the TTT results turned to be negative after ablation. And you can see before ablation, there were syncope and the drop of the heart blood pressure and sinus rhythm. 2 months ablation, although the nitrates were applied, there was no positive response. Although in some cases such results remain positive, but clinically most of the patients no longer experienced syncope after ablations. Also, if we look at the DC value before ablation, it's all above 9.5. So after ablation, even 2.5 years after that, you can see it still remained below 7. So we recently have found DC more than 7.5 could be used to diagnose the verifiable syncope if one do not have the tilt test table, or that TTT results is negative. But if you still suspect patient is a verifiable syncope, maybe perform the DC. So our first 10 cases showed very encouraging results. Then we expanded it to 61 cases published in year 2016. You can see all of them, the DC remained below 7 1 year after ablations. And the more important thing is our success rate, the free from the syncope in mixed type. It's about 90.9%. For cardioinhibitory, it is slightly higher, but there was no significance between these two groups. I think because we have a limited patient number, but that was 5 years ago that. So we analyzed there's visual depressive type. Unfortunately, by the April of year 2019, we only accumulate 19 cases. Within these 19 cases, you can see about 90% of the patients we observed this vagal reflex during the LSCP ablation. About 42%, you can to the right atrial ganglion plexus. However, the long-term results indicate nearly 90% of patients get rid of the syncope during the follow-up. Just like I said, this number is limited. Although during the past 1 more year, we get a few more cases, but we found the patient's number is still too small to make a reliable comparison. So we're going to accumulate more cases in the near future to make a conclusion. So we also noticed, instead of trying to target or ablate every single ganglion plexus, we may have a chance to achieve such a goal by ablate some limited GP, especially right anterior ganglion plexus, which locate on the anterior atrium of RSPV. In some cases, may extend it to the upper portion of the RAPV atrium. So ablation here may lead to significant increase of sinus rhythm. Also, during the atrial fibrillation ablation, if we start to ablate first from the right side, you may eliminate the chance of the vagal reflex during the PV isolation. So in summary, ablation of ganglion plexus at the left atrium effectively prevents the recurrence of vagal syncope, especially the cardioinhibitory and the mixture type. But our data indicate, with a limited number of patients, indicate it's also effective with a visual depressive type. However, we need more cases and long-term follow-up to make conclusions. And the deceleration capacity could be used to evaluate the activity of vagal tones and the ablation effects. Thank you.
Dear colleagues, welcome to my presentation about the potential usage of cardioneuroablation strategy in patients with functional AV block. In this presentation, my main objectives will be anatomical localization of GPs, selective innervation principles of sinoatrial node and atrioventricular nodal area, and we currently use fragmented electrogram-based strategy to detect the localization of GPs, and I will briefly discuss the theoretical background of this technique. And we use visual analysis of electrograms, so it may demonstrate a significant inter-observer variability, and I will briefly discuss the potential usage of a new software fractionation mapping tool of NSI system for GP detection, and I will demonstrate a sample case with AV block. If you look at animal data, Chiu et al. Defined 3 distinct epicardial fat pads area for localization of GPs, and aorta superior vena cava fat pad, right pulmonary vena and right atrial fat pad, and inferior vena cava left atrial fat pad. And in another study, Billman and Randall et al. Studied the electrogram characteristics during baseline, during vagal stimulation, and during vagal stimulation plus atrial pacing. And if you look at here, during vagal stimulation, you will see significant sinus bradycardia and then asystole, and during atrial pacing, you will see significant AV block due to vagal overactivity on sinoatrial node and atrioventricular nodal area. But if you extract inferior vena cava left atrial fat pad in here, and then apply vagal stimulation, you will still see significant sinus bradycardia, but during atrial pacing, you will not see any AV block. So you can imagine that this epicardial fat bed area is important for vagal innervation of AV node. And then they extracted right pulmonary vein and right atrial fat bed area, and during vagal stimulation, there was no any sinus bradycardia or AV block. So we can say that these two epicardial fat bed area are important for vagal innervation of sinus node and atrioventricular nodes in animals. This is important in animals. But if you look at this human autopsy spaceman, actually Armour et al. Defined at least 7 distinct ganglionated plexus sites around atria. Right superior GP located between aorta and superior vena cava, right posterior GP located between right pulmonary vein and right atrium, and posterior medial left GP located in lower part of left atrium and inferior vena cava. And these 3 GPs are the biggest ones in human. And other GP sites, left superior GP, posterior lateral or left inferior GP, and obtuse margin or Marshall tract GP. According to our fragmented electrogram-based strategy, similarly, we defined 7 distinct ganglionated plexus sites around atria. The first one is aorta superior vena cava GP. If you remember the possible localization of aorta in here, this GP is located between superior vena cava and aorta. This GP is important because it's interest point for whole vagal innervation of atria, because most efferent vagal fibers to the atria travel through this GP and then project onto the other GP sites. The other one is right superior GP, located between anterior wall of right superior pulmonary vein and superior vena cava. This is important for vagal innervation of sinus node according to animal-based data. The other one is right inferior GP, located in interatrial septum area. Posterior medial left GP is located around coronary sinus ostium, and based on animal data, this GP is important for vagal innervation of AV node. Left superior GP is located between left superior pulmonary vein and left atrial appendage. Marshall tract GP is located in ligament of Marshall area. If you remember the possible localization of ligament of Marshall in here, this GP demonstrates this site. And the last GP is posterior lateral left GP or left inferior GP, located in posterior wall of left inferior pulmonary vein. Actually, considering our anatomical data, we can imagine the possible localization of GPs, but localization of GPs may demonstrate significant difference from one patient to another. So we need some reasonable method to detect the localization of GPs during electrophysiological study. Different groups use different techniques like high-frequency stimulation or spectral analysis, but please remember that you have to use some special equipment for all these techniques, and there are some significant limitations related to these techniques. So we try to define a basic and reasonable method to detect localization of GPs without using any additional equipment. And we currently use fragmented electrograms to detect GPs. If you look at the theoretical background of this technique, in a well-designed study, LAHRS et al. Studied the electrogram characteristics according to positive vagal response during RF application. And they demonstrated that if you see more than 4 deflections in electrograms, you will see more and more positive vagal response during RF application. So we can imagine that if we see positive vagal response during RF, we are in vagal innervation site, or we are in ganglionated plexus sites. In another study, Pachon et al. Compared different bandpass filter settings to demonstrate fragmented electrograms, and they demonstrated that if you use higher high-pass filters like 300 rather than 30, you can demonstrate real fragmented electrograms. So in our current technique, we changed our bandpass filter to 200 and 500 Hz, and we try to define fragmented electrograms in the regions those are consistent with probable localization of GPs, and we tagged all these fragmented electrograms in mapping. At the beginning of the procedure, we are creating the anatomical shell of right atrial and left atrial structures. This is very important because if you remember the anatomical data of LAHRS et al., the great majority of ganglionated plexus sites are located between right atrial and left atrial structures. So you have to demonstrate this close relationship. We usually use LAT mapping to demonstrate the possible localization of sinus node area because it is important because you will see fragmented electrograms in sinus node area because all vagal innervation will converge in sinus node area for innervation of sinus node. So you shouldn't apply RF in sinus node area to prevent damage, potential damage in these sites. Then we check the phrenic nerve tracer with a high amplitude pacing, and we changed our ablation catheter with mapping catheter, and we try to find these fragmented electrograms regardless of low amplitude or high amplitude ones. Just try to find fragmented electrograms in possible GP sites. And we demonstrated that the great majority of fragmented electrograms are located in between right atrial and left atrial structures in midline. And if you remember the data of LAHRS et al., this distribution was compatible with anatomical data of LAHRS et al. Again, we use visual analysis of electrograms, and it may demonstrate interobserver variability. What about the usage of a software? In new fractionation mapping tool of NSI system, this software try to detect the number of deflections, and you can select your fractionation score in this technique. For example, if you if you select the 2 fractionation score, the map will demonstrate electrograms more than 4 deflections with white or red color. For example, during atrial fibrillation, in this vagal-mediated atrial fibrillation cases, we map the left atrium during atrial fibrillation by using fractionation mapping tool. We select more than 4 deflection sites with white color, and you can see the possible localization of white areas. This is compatible with right superior GP site, this is compatible with right inferior GP site, and this is compatible with left superior GP site. And if you look at here, during RF application on right superior GP site, AFib first converted the atrial flutter, and then we achieved sinus rhythm. What about the usage of technique during sinus rhythm? If you remember the possible localization of GPs and compared the fractionation mapping during sinus rhythm, red and white areas demonstrate fragmented electrogram sites. And if you look at here, this area demonstrates Marshall tract GP sites, and you can see the fragmented electrograms demonstrating more than 2 deflections. This area is compatible with posteromedial left GP sites. You can see the fragmented electrograms in here. Left superior GP sites and fragmented electrograms. Right inferior GP site and fragmented electrograms. Right superior GP, and finally aorta superior vena cava GP. So you can use this technique to detect fragmented electrograms, but I have to say that this technique is still not validated in a comparison study. Now we can check a sample case for AV block. If you look at rest ECG of the case, you can see the atypical Mobitz type 1 AV block on rest ECG. You can see the P wave and QRS wave in here. And after atropine administration, we demonstrated complete resolution of AV block and one-to-one AV conduction. This is very important to demonstrate functional nature of AV block. And if you look at here, during baseline, you can see complete AV block. At the beginning of the procedure, we created the anatomical shell of left and right atrial structures, and you can see the intracardiac electrograms in below. Then If you remember, posteromedial left GP is important for vagal innervation of AV node, so we started the procedure via left atrial ablation in this GP site, and we saw a significant sinus bradycardia, and there is still AV block. We couldn't achieve one-to-one AV conduction. Now we went to the right atrial part. We performed ablation in the right atrial side of this GP. You can still see significant sinus bradycardia and AV block. We couldn't achieve one-to-one AV conduction. And then we went to the right superior GP site. If you remember, this site is important for sinus node based on animal data. But if you look at here, you can see sinus bradycardia and AV block. We started the ablation. We can see a steep increase on sinus rate here. And here we go. We achieved one-to-one AV conduction via ablation of right superior GP site. So again, based on animal data, there is a selective innervation principles in sinus node and atrioventricular node area, but in human, there is a very, very complicated interconnection between different GP sites. So in human, we have to remember this very complicated innervation principles. So in some cases, you may have to perform ablation in all GP sites to prevent AV block episodes, and you can see the final lesion set. Regardless of intermittent or persistent nature of bradycardia, if you can demonstrate the simple characteristics of functional AV block, for example, in functional AV block, you will see significant sinus bradycardia during AV block episode. This is very, very important to differentiate functional and structural AV blocks. And if you see persistent bradycardia, you should check atropine response, and you have to demonstrate one-to-one AV conduction after atropine administration. And you should perform electrophysiological study to demonstrate suprahystian nature of AV block, and then you perform cardioneuroablation. As a take-home messages, GPs demonstrate clustering in well-defined anatomical areas. Their localizations can be detected by using electrogram characteristics, and in well-selected patients with AV block, cardioneuroablation might be attempted as a first-line strategy. Thanks for your attention.
Hello everyone, it's a great honor being here at this virtual session of Latin American Heart Rhythm Society, sharing our experience with this novel EP procedure. My name is Juan Carlos Serpa. I'm a cardiologist and electrophysiologist at the Hospital do Coração in São Paulo, Brazil. I'm glad to talk about the role of the cardioneuroablation and pulmonary vein isolation for the treatment of vagal atrial fibrillation. All the members of our group has been active and essential for the collection of the information we use for our publications and this presentation today. There is nothing to be disclosed. Let's see some background. Since the early 2000s, this hybrid approach became a standard in our service for ablation of paroxysmal and persistent atrial fibrillation, considering that Dr. Pachon observed a significant improvement in the results of PVI when associated with cardioneuroablation compared with either PVI or GP ablation alone. In 2004, Dr. Pachon's group published the first evidence of this work, describing the atrial fibrillation nest as a substrate of the atrial fibrillation origin, mainly located in the fibrillar myocardium. At that time, they observed that the ablation of the AF nest resulted in vagal denervation and also allowed the treatment of atrial fibrillation. These findings were also published as U.S. patent registration of the AF nest in 2005. Authors have described experimental studies using high-frequency stimulation and epicardial ablation that partial denervation prevents atrial fibrillation induction, changing the atrial effective refractory period. Now, with this actual cardioneuroablation technique, results are a little bit different. Let's see this in practice. This is a young man of 41 years old that was referred to us for having paroxysmal crisis of irregular palpitations, chest discomfort, and syncope episodes. Suffering from this since the last 10 years, increasing in frequency and duration, counting 5 episodes of syncope the month before he came to our office, preceded by lightheadedness, weakness, nausea, with full recovery after each episode. Atrial fibrillation episodes were nocturnal and postprandial. As past medical history, he had coronary artery disease, being submitted to an angioplasty for LAD in 2017. He was treated with propafenone and atenolol with mild effects of the arrhythmia and then was changed to amiodarone but persisted with symptoms. Some visits to the ER and one needed electrical cardioversion. So at this point we consider this possible diagnosis: progression of coronary artery disease, paroxysmal atrial fibrillation with rapid heart rate and instability, sick-sinus syndrome, vasovagal syncope, or orthostatic postural hypotension, or an association among them. At the physical exam, he had a mild bradycardia, normal blood pressure, no postural hypotension, and no other abnormalities. The echocardiogram confirmed the absence of valvular or structural heart disease, normal left ventricle ejection fraction, and non-dilated left atrium. Functional test and CT scan showed no new obstructed CAD, and 4 pulmonary veins with normal shape and position. Neurological evaluation was normal too. Now an EKG from one of the visits to the ER during an atrial fibrillation episode at midnight. This time he was treated with electrical cardioversion, and after this event he was referred to our arrhythmia service. This other electrocardiogram of the first consultation in September 2018. Here we see a sinus bradycardia with a heart rate of 49 beats per minute, with no other significant abnormalities. We can observe some interesting details during this Holter recording. The heart rate variability in time domain showed parasympathetic prevalence with an SDNN over 100 milliseconds, several PACs, and another atrial fibrillation episode at midnight. We perform a head-up tilt test, and when standing to 70 degrees, we can observe an initial sinus tachycardia, followed by a sudden decrease of the heart rate. The blood pressure went down too, with syncope. The patient referred the same symptoms he had during spontaneous episodes, featuring the correlation between the EKG and symptoms. On the EKG registry, during the exam, we can see sinus bradycardia followed by a systole of 8.1 seconds, recovering after minus 30 degrees in Trendelenburg position. We consider some treatment options to follow. Maybe treatment of the cardioinhibitory response with a pacemaker, atrial fibrillation ablation with PVI, maybe another antiarrhythmic drug, or performing PVI plus cardioneuroablation. Discussed this with the patient and the family. He was not too happy with the pacemaker idea, and after a long talk we considered doing atrial fibrillation ablation, and we agreed to try to abolish the cardioinhibitory response, performing also cardioneuroablation. Before and after the hybrid approach, we did an EP evaluation, and here there is a comparison of the pre- and post-ablation results. Initial heart rate was 51 beats per minute, and at the end 88 beats per minute. Normal sinus node automatism, with a sinus node recovery time of 1,424 milliseconds, and after 1,191 milliseconds. Wake up point increased from 153 to 173 beats per minute. Dr. Pachon published in 2015 on JACC a method for vagal effect evaluation in cardiac ablation and electrophysiology procedures. So we proceed with the extracardiac vagal stimulation by introducing a quadripolar deflective catheter to the internal jugular vein up to the jugular foramen. And here, proximal to the vagus emerging site, we apply the CVS. This is an example from this work from 2015. And here we see an atrial fibrillation typically related to an increased vagal tone, showing vagal stimulation, tracing and systole, an atrial fibrillation induction, and a totally different response after cardioablation without pulse and without arrhythmia. We performed the CVS, and this was the result. Before ablation, the vagus nerve stopped the heart, causing the tracing and systole, and then, as effect of vagal innervation, atrial fibrillation shows up. And by this, we can conclude that vagal drive was a contributing trigger for atrial fibrillation in this patient. That explains the cardioneuroablation role in atrial fibrillation ablation. If we can abolish this vagal drive, it could be more difficult atrial fibrillation occurrence, at least in episodes of vagal tone increase. And this could be an upgrade of the atrial fibrillation treatment in this kind of patients. These tests were repeated a few times with the same response, showing high reproducibility. As the pulmonary vein isolation is the universal atrial fibrillation ablation cornerstone, our approach consists in PVI plus cardioneuroablation. In this slide, I want to show another simple way for esophagus protection during PVI that Pachon developed at the beginning of the century, pulling the esophagus away from the position of the radiofrequency delivery. By this, using a transesophageal echo probe, avoiding esophagus overheating and injury, with over 700 patients in this report. And PVI was well succeeded in the 4 veins. One important clue is that cardioneuroablation, guided by only GP anatomical position, does not cause pulmonary vein isolation. PVI alone does not achieve enough parasympathetic denervation. However, cardioneuroablation, guided by AF nest ablation, that was the technique used in the initial publication in 2004, causes behind the vagal denervation also pulmonary vein isolation, because a great number of AF nests that are located at pulmonary vein antrium, achieving the most important AF ablation technique as proposed by Dr. Saisaguerre, Papone, Natale, and others. And this is what we look for, these kind of potentials, the AF nests, that are usually related to vagal innervation. They may be located by using spectral analysis by conventional recordings. An easy way to find this fibrillar myocardium is to set the recorder filtering to 300 to 500 Hz. We can see the features on the tip of the ablation catheter. In 2015, Dr. Rivarola, and 2017, Dr. Toga published articles reproducing the recording of the fibrillar myocardium, typically more frequently overlapping the areas of ganglionated plexuses. Another way is to use the fractionation software of the insight velocity function that help us to tag these potentials, defining the surface with Field Explorer. When we ablate the fibrillar myocardium, it is quite common to have vagal denervation response, like sinus rate increase and shortening of the PR or AH intervals. During left pulmonary vein isolation, the radiofrequency over the GP4 may cause vagal-induced bradycardia or even asystole, and this is a good sign for denervation, and this region must be widely ablated. Then moving to the GP2, related to the P point in the left interatrial septum between the fossa ovalis and the insertion of the right superior pulmonary vein and left atrial roof. The wide ablation of this triangle is the main step of the cardioneuroablation described in the first publication in 2005. We proceeded with the ablation of the GP on the lower interatrial septum over the coronary sinus roof. And then we check again our TDS. After completed left atrium treatment and still a mild bradycardia response. So there is still more work to do here. We move to the right atrium and we proceed with the treatment of the GP1 on the superior vena cava and right atrium junction. Then go down to the right side of the upper interatrial septum, treating the B point also in the right interatrial septum. And then GP3 was also treated in the coronary sinus ostium and in the lower interatrial septum close to the IVC. Then we check again our CBS, and this is the final result. No more systole, no more bradycardia or AV block, and the most important, no more atrial fibrillation vagal induced. At the end, we also did the atropine challenge using 2 milligrams of atropine, and there was no increase in sinus rate. And now let's see the follow-up. At the 5th month, we repeat the Holter and the head optic test. The Holter shows a median heart rate of 95 beats per minute, and no atrial fibrillation episodes. The head-optic deaths showed an initial heart rate increase, but no bradycardia, no syncope, and no symptoms on the same conditions compared to the one pre-cardioneuroablation. Here we can see an electrocardiogram at 12 months with 96 beats per minute and 25 months after 80 beats per minute resting. And two different 24-hour Holter recording. One before cardioneuroablation with 124 milliseconds of SDNN, and the other with a long-term follow-up completing 23 months with an SDNN of 66 milliseconds without atrial fibrillation. The patient recovered cells of Stearns, quality of life, and he did not report new atrial fibrillation episodes, syncope, or presyncope. And where we are now. We are working in a new study headed by Dr. Pachon and Dr. Carlos Morillo to analyze atrial fibrillation ablation results with PVI alone versus PVI plus cardioneuroablation, including patients equivalent to the RAV2 trial, now submitted to PVI plus cardioneuroablation. And here we can see the initial results, showing that the hybrid approach may significantly improve the results. And now, some take-home messages. This case confirmed the important role of vagal drive in the pathogenesis of atrial fibrillation. In patients with classical vagal triggers for atrial fibrillation, PVI plus cardioneuroablation appears to be safe and efficacious for improving PVI results. Extracardiac vagal stimulation is an important step for confirming the degree of denervation achieved, getting the hard endpoint for cardioneuroablation. Cardioneuroablation is an effective and safe treatment option for refractory cardioinhibitory syncope. Randomized controlled trials are needed to confirm the efficacy of this novel treatment. I'd like to invite you to visit our website at www.cardioneuroablation.com, where you can find more references about this interesting subject.
Well, thank you very much. That was a fantastic session. And Dr. Shiv Kumar is here today with me, and I don't know if he has any comments. We'll go to the chat box in a second and answer some questions. But again, there's a lot going on. This session was amazing, and I actually have like 13 points that I would like to discuss. But I'll let Dr. Shiv Kumar go first and see if he has anything to add.
Thank you so much, Dr. Morillo. And most of all, I wanted to thank Dr. Morillo and also all the speakers in this session for a phenomenal session, and also to the Latin American Heart Rhythm Society for really shining a light on this important area. We owe a lot to the investigators who presented in the session, especially Dr. Pachon, who really brought this from the clinical end to everyone's attention, and to Dr. Aksu, who's done very tough, interesting studies to shine a light on this. So there are incredibly good questions that have come up from the audience, and we look forward to hearing from the speakers about these specific questions. I'd like to make one comment upfront to everyone, and that is, this is an area where we are now doing a lot of mechanistic basic science in humans. Therefore, I think this is one area where the scientists really have to provide more tools. And I think you're going to be seeing a lot of data in the next 2 to 5 years, which I think is going to be very valuable for the field. So I'll turn this over to Dr. Morillo so that we can read out the questions and ask the various speakers to respond. Again, very exciting session. Thank you.
Yeah, and I guess thanks. There's lots of questions. So there's one question is that if you always, for neurocardiac ablation, do ablation of the right and left plaque side for either indications, because today we saw vasovagal syncope, AV block, and atrial fibrillation. So I guess that the three of you or the four of you can answer in the order. First, because of seniority, Professor Pachon, why don't you go first?
Thank you so much, Carlos Murillo and Dr. Professor Shiv Kumar. And thank you for the participation of all of you. About the cardioneuroablation, I think I have to remember that the innervation in the heart, in the atrium, the innervation is higher in the endocardium than in epicardium. So the ablation must be done from the endocardium. And also the innervation is higher in the left atrium than in the right atrium. So the cardioneuroablation must include the left atrium in order to get results. And I think the best way is to ablate all of ganglia, because many times we see the asystole. However, if you stimulate the atrium, we can see the high degree AV block. And many times we can see AV block, but if we study both vagus, it's possible to see asystole. So I think if we want to have a complete cardioneuroablation, it's very important to ablate from the right atrium, from the left atrium, and all places of at least the 4 main GP.
Great, but Professor Yao actually showed some really nice data in which he's targeting only the right ganglia as probably the first step. So when you say this is the first step, how many times do you have to go to the left atrium during the follow-up to control vasovagal syncope? And most interestingly, because this technique was pretty much fathered for cardio inhibition, but you're also using it for vasodepression. So can you tell us a little bit of what do you think is the mechanism? Because this is different afferent and efferent loops that we will be affecting.
Okay, just like Dr. Sakuba just mentioned, we start this work directly on human, so without much evidence from the experimental study. That's something we really need to do in the future. And if you ask me to answer the mechanism of this, frankly, I don't know that clearly. So we just noticed that phenomenon. And it seems like the right anterior ganglia plexus played a very important role in this whole left atrium ganglia plexus system network. So this one, some people believe might be the head station, or somehow the connection between the central nerve system and this intrinsic ganglia plexus system. So we just noticed that. We actually do not directly ablate this part first, but we target the whole left atrium, and then we would like to ablate the other ganglia plexus before, and take this GP as the last one to ablate. Otherwise, once you ablate this RAGP first, you wouldn't see any vagal reflex in the left atrium if you want to ablate later. So we are trying to compare whether we can just achieve a success like that other doctors like Dr. Juan Zephyr introduced before. We may achieve the success simply on the right side, just below the SVC. So you can only penetrate to the left IAGP also. So this might be a solution Thank you.
Yeah, great. So Professor Shiv Kumar, you've done a lot of basic science and translational work on this. Any hypothesis on the mechanism, why this is working also for vasodepressor response?
So it's a great question. So there are inhibitory reflexes that originate from the heart. So anytime you, much like how if someone gets an IV, they could faint, which is pain being the trigger, a vagal trigger. Similarly, when the heart stretches, some people are very sensitive to volume changes. So much like how in an extreme example, in an inferior MI, you see hypertension and bradycardia, the basal-gyrus reflex. So I think what the studies that Dr. Pashon shows actually has a very good scientific basis. So it's probably just preventing the signal going from the heart, which triggers a massive vagal response. Therefore, bradycardia is one expression of it. Hypertension is another limb of the same reflex. So that is probably what drives it. And just in the chat, I've posted a paper, and I've also posted a PDF for the audience to look. It's in the Open Archives. I'll also post the PDF. Hopefully, they can just click that link. But this is, you're going to see a lot more data. And as we are keeping our end of the promise to follow the lead of Dr. Pashon, Dr. Yao, and Dr. Aksu, this is just all the people who spoke here are the world experts on the human data. And we are now collecting a handful of cases we ourselves are ablating. And maybe at the end of this talk, if we had 30 seconds, I'll show a small video that shows you the exact structure that all the experts in this talk presented. It's a great emerging field to keep track of.
Yeah, I agree. So there's some questions from Dr. Science, who has several questions, all very interesting. One, given the fact that we don't all have these neurostimulators, so is the efficacy of the cardioneuroablation just doing it by anatomical approach, or do you always need some sort of cardioneural stimulation like the Pashon approach or high frequency stimulation? And the other question is that, you did show that you do a lot of lesions. Are these lesions proarrhythmic? Do they produce atrial tachycardias?
Actually, for the second question, in our studies, the mean number of ablation point was 25 or 26. So actually, there is a significant difference between classical PVI lesion set and ganglionated plexus ablation. Actually, we try to find the real point for vagal innervation in that procedure. So we don't have to perform very extended ablation lesion set in this approach. And as another important point, actually, we all believe that these GP sites are epicardial and found in very well-defined area. But if we look at the human or animal anatomical data, we know that there is at least 700 ganglia around atria in human. So we just try to define a possible clustering site of this ganglia, and we are trying to target this area in our current strategy. So I think that high frequency stimulation is a very useful method to detect the localization of GPs, and in our previous studies we tried this method to detect localization of GPs, but we currently use just electrogram analysis. Why? Because we realized that in normal cardiac patients without any structural cardiopathy, without any fibrosis in left atrium, if you see fragmented electrograms, there should be a cause of this fragmentation. And I think that Professor Pachon clearly explained it. The nerve incursion from epicardial part to endocardial part, the main cause of this fragmentation in this clearly healthy area. So in close times, we performed 2 transatlantic proctoring by just using these fragmented electrograms. And 2 procedures were succeeded without any complication or without any problem, without using any additional equipment, not high frequency stimulation or not any other tools. We just checked visual analysis for fragmentation, and we also confirmed that our visual analysis and fractionation mapping tool of NSIGHT system demonstrated very close area for localization of these GPs, and we demonstrated clear vagal responses in all GP sites, in left superior GP, in martial thorax GP, in left inferior GP. We saw positive vagal response in all different GP sites, and we achieved a steep increase on heart rate after ablation of right superior GP. As a last point, why we see positive vagal response in left-sided GPs, but we don't see any vagal response and only see a steep increase on heart rate in right superior GP side? I think that if you look at animal data again, the number of parasympathetic and sympathetic neuronal bodies are not same in all different GP sites. For example, in left-sided GP site, we see more parasympathetic parasympathetic neuronal bodies, and I think that the main cause of this difference between vagal responses in each GP site may be related to balance between sympathetic and parasympathetic neuronal bodies number.
Okay, great. You opened the door for a couple of other questions, like, you know, can you give us a little bit of idea what are the RF parameters you use? Is it the same when you're doing a cardioneuroablation for AV block or for vasovagal syncope? Do you change anything? Contact force, high power, a little bit about that. And the second one is, you know, you talk about your fractionation. So what's your endpoint? Do you eliminate all the fractionated responses? How do you know when you finish the procedure? Is it because you're not inducing any more bradycardia when you're applying radio frequency there? Just give us a little bit of a idea of how this works.
Actually, we have two endpoints, ablation endpoints. The first one is complete elimination of electrograms in the fragmented electrogram sites. This is the first ablation endpoint. But again, we nearly always see positive vagal response in left-sided GP sites, in all left-sided GP sites, more than 80% of the case. So we also try to completely eliminate positive vagal response in these GP sites after ablation points. And we don't use high power in any cases. We use 35 watt in anterior wall. And if you remember the anatomical distribution of GPs, we only perform ablation in posterior wall in left inferior GP sites, and we decrease our RF power to 40 watts in 30 watts, sorry, in this GP sites.
Great. And just one last question. So which are the patients that are ideal for cardioneuroablation and AV block? How do you choose those patients?
This is a great question. Actually, the most difficult cases for cardioneuroablation will be the AV block cases. Maybe Professor Pachon and Yanyo will agree with me about that, because it is not easy to differentiate structural ones and functional AV block. But if you see just a paroxysmal AV block episodes, it's a little bit more easier to differentiate functional ones, because you will usually see sinus bradycardia during AV block episodes. It's very important to differentiate structural ones, and you also usually see a PR prolongation just before the high degree AV block episodes in functional AV block ones. But in persistent AV block, you have to demonstrate complete resolution of AV conduction after atropine administration. This is very important, but it's not enough to say, yes, this is completely functional, because in some intrahischian AV block cases, you may see a partial atropine response, but you have to demonstrate suprahischian nature of AV block by using electrophysiological study in persistent AV block cases. This is my approach.
Okay, great. Now let me ask some philosophical questions to the group in general, and you know, maybe a little bit about vagal AF ablation. So because, you know, if you just do this for people with paroxysmal atrial fibrillation, apparently it's not that successful. So how do you figure out that these are really exclusively vagally mediated atrial fibs? I actually had a case this week of a very interesting patient that has some Barrett's esophagus, and they actually treat him with radio frequency of the esophagus, and that triggers atrial fibrillation. So do I need to do a vagally mediated oriented AF ablation in this gentleman?
Well, let's see, that's interesting question. What we are using to treat these patients, in this case specifically that I present today to, he had specifically vagally induced atrial fibrillation. it was at night. We could induce that during vagal simulation too. And when you suspect this is an especially kind of patients that have vagal atrial fibrillation, maybe, and that's why the question we are getting up here is that maybe this could be an upgrade to the atrial fibrillation treatment. We have the experience doing this treatment in paroxysmal and persistent atrial fibrillation with good results. We still have to publish this work that these results are a little bit better than conventional technique. Maybe you have isolated, you could achieve pulmonary vein isolation, and you took out the vagal reflex that induced the atrial fibrillation. That's a condition that will not be repeated in the future. So that we have to see that it is better or not. The initial results shows that we have an improvement of this. Our experience also talks about the beneficial effects on these too.
That's great. So Dr. Figueredo brings up a point that I was going to bring also from the philosophical perspective, because when I started my career in autonomics with Dwayne Eckberg, and even before in the early 90s, trying to get rid of vagal response was bad. Actually, increasing vagal activity reduces heart failure, reduces sudden cardiac death, improves outcomes. So tell us about what's the long-term follow-up of these people. Although most don't have structural heart disease, they're pretty young patients. What is going to happen with their vagal modulation later in life?
Yes, that's something that we are working on too. At this moment, we have published a recent work with the long-term results and the effect that the cardioneuroablation has over the arrhythmias. And you have an excellent result without increase of the atrial, the ventricular arrhythmias. So the pro-arrhythmic effect that we think that with taking out the vagal effect that may be protective, we can have a balance during the vagal and sympathetic denervation too. And over the time, this effect remains with a good result without augmenting the pro-arrhythmia effects. I think Dr. Pachon may have an opinion about that too.
Hello?
Yep, we can hear you.
Okay. This issue is very important, and we have to take into account that after, for example, the myocardial infarction, there is a decrease of the vagal tone and an increase of the sympathetic tone. And after cardioneuroablation, there is a reduction of the parasympathetic tone and reduction of sympathetic tone. It's a scenario is a completely different from for example, after myocardial infarction or in patients presenting low ejection fraction. So I think the balance that we can get after cardioneuroablation is very good for the patient, and we can see this by following this patient, like Dr. Zerpa told, that there is no increase of the arrhythmias. On the other hand, there is a very, very important reduction of the ventricular arrhythmias. We can see this in for example, in the study we did in patients after presenting heart failure and atrial fibrillation. The ablation of these patients with isolation of pulmonary veins and also by cardioneuroablation showed a very good outcome, even with increase of the ejection fraction, reduction of symptoms, and elimination of the atrial fibrillation.
Yeah, great. No, there's lots to learn here. So this has been a fascinating session. I'm going to let Dr. Shiv Kumar wrap it up and maybe show us this little video, but I'm also going to invite you all to maybe we should create this consortium of cardioneuroablation to try to answer all these questions in a more systematic and translational way. So it's been a pleasure to be here with you guys, and I'm going to let Dr. Shiv Kumar wrap up the session. We can't hear you, Dr. Shiv Kumar.
So sorry, I just unmuted myself. So I'm just playing this, a little picture on the screen there as a little electronic video gift to all the speakers. This paper has just been placed online, and this is the right atrial GP, which we saw a beautiful presentation by all the speakers as a target. And this is human RAGP. So we are now going to be learning a lot from many groups in the world, including ours. And we are looking forward to the next decade in this area, because the science is very exciting. And I really would like to point to the listeners, and also take this opportunity along with my co-chair to really thank the speakers for a brilliant presentation. It's a whole new world out there in terms of what you're going to be seeing in the intrinsic neurons and the heart's little brain. So I'll stop here and turn it back to my co-chair. And again, thank you, Professor Pashon, Dr. Aksu, Professor Yan Yao, and Dr. Zerpa for an extremely good presentation. And to all our friends in South America, post-pandemic, we look forward to meeting you again in person. Professor Murillo.
Yeah, well, thank you very much. This was a very exciting session. I thank you all for spending the time, being up so late for Dr. Yao and Dr. Aksu, and actually congratulating Dr. Sanz, Dr. Figueiredo, and all the organizing committee of the Latin American Heart Rhythm Society for a fantastic session. I've been actually able to log in into most of these sessions throughout the last 2 weeks. Even I have learned a lot, and I'm an old dog. So I can tell you that this has been a fantastic virtual experience. And I hope that we can see you soon and get together and have a beer or a caipirinha or whatever, even a Coke, something that stimulates both the sympathetic and the vagal systems.
Exactly.
Take care, and we'll see you around.
Sure. Sure. Thank you. I want to close the live sessions. We have reached the end of the live models of the LAHRS 2020, and I want to thank to all the attendants that were connected today, and to the chairs and speakers that participated. I would like to thank also to the companies that supported LAHRS 2020 that have been supported any initiative in our society. I also want to announce that based on the many requirements from colleagues, we will keep the platform activated and open for 1 week more for your convenience. So please remember to see the contents of the program in the format on demand in the next days. Finally, I want to invite the members of LAHRS to connect to our annual assembly that will start in 5 minutes. Thank you very much to all.